Uh, so we have already discussed about the customization of occlusal rims, and now next we will discuss about recording of jaw relation. So jaw relations can be broadly classified into three: orientation jaw relation, vertical, and horizontal jaw relation. So in this lecture, we will discuss about orientation jaw relation. What is jaw relation? It is any one of the infinite spatial relationship of the maxilla to the mandible. And the jaw relation record definition is a registration of any positional relationship of the mandible related to the maxilla. These records may be made at any vertical, horizontal, or lateral orientation. So now we will discuss about orientation jaw relation. What is orientation jaw relation? So definition according to the Boucher is are those that orient the mandible to the cranium in such a way then that when mandible is kept in its posterior most position, it can rotate in the sagittal plane around an imaginary transverse axis passing through or near the center of condyles. So sagittal plane, what is sagittal plane? It's a vertical plane which bisects the body into two parts, left and right. So in the sagittal plane, when we will see, then the mandible is in the posterior most position. It can rotate it can rotate around an imaginary axis which is passing through the center of condyles. This is the orientation relation, and this is the record which we need to make for the orientation jaw relation. So what is the axis? What is this axis? This is the hinge axis around which the condyle can rotate and which is passing through the center of the condyles. And this axis can be recorded by means of the facebows. So we can see in this diagram, like this is an imaginary axis which is passing through the condyles. And along this axis, what kind of movement mandible is making? That is only pure rotational movement. There is no translation movement, only pure rotational movement. Like when the mandible is in the closed position and as soon as it opens, and opens only to 13 to 14 degree, and the maximum interincisal opening allowing rotation in the condyle is only 20 to 25 mm. In this range of movement, the axis along which the condyle will rotate only. There will be only rotation on the condyle. There will be no translation along the rotation means it is moving in the same space. So the line along which the rotation of the condyle occurs is the transverse axis, hinge axis. This in this we have mentioned about the sagittal plane. It is any vertical plane or section parallel to the median plane of the body that divides a body into right and left portions. Okay. So what is we have discussed already about hinge position, that is the rotational movement that occurs during the rotational movement of the condyle. And terminal hinge position is also called the retruded contact position. It is that guided occlusal relationship occurring at the most retruded position of the condyles in joint cavities. So maximum range of terminal hinge rotation is about 12 degree and interincisal opening is 18 to 25 mm. So this is the when the mandible is in the most retruded position, in the posterior most position. So condyles and joint cavities will be in the terminal hinge position. What is so how will we record the orientation jaw relation, and why are we recording the orientation jaw relation? We record the orientation jaw relation so that the base, like just imagine we are fabricating, not imagine, we know that we fabricating dentures between the jaws. So we need to record the relationship of the maxilla anterior posteriorly, vertically, laterally in relationship to the base of the skull, in relation to the cranium. We know that maxilla is a fixed landmark and mandible is a movable landmark. Condyles of the mandible can move, and mandible and maxilla are related to each other, and they both are related to the base of the skull. They are both are related to the cranium. So we need to record this relationship of the maxilla. If we will record this relationship of the jaws to the base of the skull, to the opening axis of the jaws, to the opening axis, then we can stimulate the same relationship to the we can transfer the same relationship to the articulator, and as the same relationship of the it will stimulate the same relationship in the articulator, then we can fabricate the processes in the also the same manner as it will be in the mouth. And the processes which are fabricated in harmony with the movements of the temporomandibular joint, they will have less occlusal discrepancies and will give more comfort and more function. So this is the reason why are we recording the orientation jaw relation. And maxilla, there is a tilt of the maxilla in every patient. There is a different anatomical tilt, different anatomical variations. Ask us to record the orientation jaw relation in every patient. It makes necessary for us to record this orientation jaw relation. So, and how are we going to record this? With the help of facebows. Facebows is a device which will help us to record the relationship of the maxilla and mandible to the opening axis of the jaws. We are not recording it to any relationship of the jaws to any anatomical reference point, anatomical points. We are recording the relationship of the jaws to the relationship of the maxillomandible to the opening axis. And when this relationship is recorded, it is transferred to the articulator. So the casts are articulated in the same opening axis as in the patient's mouth, and we fabricate the processes in the same way. So facebows are helping us to record this relationship and transferring it to the articulator. What is facebow? It is a caliper-like instrument which is used to record the spatial relationship of the maxillary arch to some anatomical reference point or points, and then transfers this relationship to an articulator. Why are we calling this caliper-like device? Because it is measuring something. It's an instrument which is measuring. So facebow, what definitions contain? It orients a dental cast in the same relationship to the opening axis of the, like if we see the maxillary cast in this, there's a tilt, there's a relationship of the maxillary cast to the in the space, in anterior, posteriorly, vertically, laterally, there is a relationship of the maxilla. So facebow orients a dental cast in the same relationship to the opening axis of the articulator. And how are we recording this? We are taking some reference points in the patient's mouth so that we can use those reference points to articulate the cast. Customarily, the anatomical references are the mandibular condyles, transverse horizontal axis, and one other selected anterior point. So these are the parts of the facebow. Facebow is a caliper-like device which is used to record the relationship of the maxilla to some anatomical reference point. So these are the these are the parts of the facebow which will be using. So parts first is the U-shaped frame. It is the like spring-like assembly which is wide enough to avoid contact to the sides of the face, and it can be used to. And it is the earpiece type of facebow. It's a Hanau facebow, and in these points, they are this acts as a posterior reference points, and they enter. We put it into the patient's ear, so they are So the posterior reference points which we'll be using in the Hanau facebow will be the earpiece. And in the condylar rods, they are also used. And the condylar rods, they are the we use in fascia type of facebows, and they are marking the points on the face, on the side of the face, and they are not inserted into the external or auditory meatus. Earpieces, they don't have earpieces, they have the condylar shafts which are located on the patient's on a reference point on the patient's face. We mark the point like 13 mm anterior to the anterior border of the tragus, and we fix the condylar shaft on this point. So that it acts as a posterior reference point. And an earpiece type of facebows, the earpieces are inserted into the patient's ear and external auditory meatus, so they act as a posterior reference point. The next part of the facebow is the bite fork. Bite fork, this is the part which is attached to the maxillary occlusal rim, and in like in the, if we have to use it in the dentures patients, then we have a bite plane for that. So bite fork is inserted into the maxillary occlusal rim, but it should be inserted 3 mm above the plane, so that while recording, they should not interfere with the occlusal plane. This is the locking device. This is the device which helps to lock the U-shaped frame and the stem of the bite fork with the U-shaped frame and the bite frame into one assembly. So locking frame is used, locking device is used to tighten all the things in place. Orbital pointer, it acts as an anterior reference point in this kind of facebow, Hanau facebow, and this is the orbital pointer is like inferior orbital margin is palpated in the patient's mouth, and orbital pointer is located at is placed at that position. So we get an anterior reference point with the help of this. See this planes and facebook. Planes are the flat section defined by at least 3 points in a space. Like we will mark 3 points, then it will make a plane for us. So Facebook captures the relationship between the occlusal plane and the horizontal reference points. We mark the horizontal reference points on the patient's face, and on the patient face on the using the patient's anatomical landmarks, and with these anatomical reference points, with these with the one anterior and two posterior reference points, give us an horizontal plane, and this plane of orientation helps us to orient the maxillary occlusal plane in the articulator. This is the plane of orientation, which is a spatial plane formed by joining the anterior and the posterior reference points. So horizontal plane is established on the face of the patient by one anterior and two posterior points, from which measurements of the posterior anatomic determinants of occlusion and mandibular motions are made. See this, this is the horizontal reference plane or a plane of orientation. These are the two posterior reference point, and this is the one anterior reference point. So that this, and we need to make our cast parallel to this this horizontal reference plane. What are the anatomical reference anterior reference points used in different kinds of articulator? Orbital. Orbital, which is used in Hanau, located by Hanau Facebook with help of orbital pointer. This is orbital B. In the, if we will check the infraorbital margin, there's a in the midline, in the mid portion, there's a will feel the can feel the notch, and that notch can be helped is the anterior reference point, which is used by the Hanau Facebook, and that is orbital. And next reference point, anti-reference point, which is used in another kind of articulators, is the Frankfurt's horizon plane, which is marked by orbital minus 7 mm. Marked an orbital and minus 7 mm will mark the horizontal Frankfurt's horizontal plane, which is extended from orbital to podion. So next is in the next anti-reference point is the nasion. This is marked as A in this diagram, and it is used with the whip mix articulator, quick mount Facebook whip mix, and this is the in the midpoint of the nose. This is another anti-reference point. All of the nose is also marks a campus plane. Like while customizing the rims, we made the posterior portion of the rim parallel to the anterior posterior border of the rim, parallel to the campus plane, that is all of the nose to the tragus of the ear. So all of the nose will act as an anterior reference point. And for the dinar articulator, we mark this as the 43 mm superior from lower border of the upper. This is the upper lip, lower border of the upper lip, so 43 mm superior. So this anti-reference point is used by the dinar Facebook. Orbital is the lowest point on the intraorbital margin, palpated through tissue and skin. One orbital and two post-reference points marks the axis orbital plane. It is used because it is of ease of location and is very easy to understand. Orbital minus 7 mm, Frankfurt's horizontal plane. Podion is a fixed point on the skull and is considered as a posterior reference point, posterior landmark. And Frankfurt's horizontal plane passes through podion and orbital. Nasion minus 23 mm. Another skull landmark, nasion, is located in the head as the deepest point of the midline depression, just below the level of the eyebrows. So it is used with the whip mix articulator. All of the nose, tentative occlusal plane should be parallel to the tentative occlusal plane, which we mark should be parallel to the horizontal plane, and this can be achieved in two ways. All of the nose to the center of the auditory meatus campus plane. An occlusal rim is marked parallel with the campus plane. And what is the advantages of anterior reference point? First, it acts as a plane which will become the plane of reference to articulate the cast. It determines the level at which the cast are mounted. Similar, to establish a baseline for comparative studies between patients. Like we are using a landmark, the anterior reference point. It is acts as a baseline so that when we are comparing two patients, and it standard landmark we are using, and it can visualize anterior teeth and occlusion in the articulator in the same frame of reference. So next is the posterior reference point. What are the points which we're using as posterior reference points? Like a Beron point, which is 13 mm anterior to the posterior margin of the tragus to the outer canthus of the eye. First, we'll mark a line from the posterior margin of the tragus to the outer canthus of the eye, and the Beron's point will be 13 mm anterior to this line. So Geissy point is 13 mm anterior to the anterior margin of external acoustic meatus. Another point is the snow, which is 11 to 13 mm anterior to the tragus, and the Dinar point, which is 12 mm anterior to the posterior border of the tragus and 4 mm inferior to the line from external acoustic meatus and outer canthus. These are the some posterior reference points you need to remember. What is the significance of Facebook record? It helps us in accurate mounting, like 3 points we're using. Criteria for selection of points are the ease of location, convenience, reproducibility. So now I need to take a Facebook record. What are the steps? What are the steps which we will follow? First, seating the patient. Patient should be sitting in an upright position with the headrest, with the head supported by the headrest, and mark the positions for the condylar position, points for the condylar position, and reference points like posterior reference points, and attaching the fork to the occlusal rims. This is like the bite plane, which is attached to the maxillary cusp. And the dentures patients, bite fork preparation is like this. We'll attach the bite fork to the maxillary occlusal rim 3 mm above the occlusal plane, like this, and should be attached firmly. And this line we can see, this line should coincide with the midline of the maxillary occlusal rim. And it should be pierced and rigid and should not distort the occlusal surface. For bow preparation, now this U-shaped frame is attached, is a bite stem of the bite fork. First, we'll insert the stem of the bite fork into the patient mouth, and we should see that it should be parallel. It should coincide with the maxillary midline and with the midline of the patient's face. And we should, if viewing from the side and from the front, it should be parallel and should be straight, not tilted. Because if it is not straight, if not parallel, then it can affect the recording. Bow preparation. U-shaped frame, then it is inserted into this earpieces of the U-shaped frame inserted into external acoustic meatus, and then it should be loosened. And then after that, after inserting this, we'll attach the locking assembly. Locking assembly has a transfer rod, which is a vertical rod, and the transverse rod, which is a horizontal rod, and which has the thumb screws. So transfer rod is inserted like bite fork. First, we insert the bite fork into the patient mouth, and then we'll insert the U-shaped frame and attach the locking assembly, which is attaching the bite fork and the U-shaped frame to the locking assembly. Then we will check, we'll move the locking assembly up vertically so that the orbital should reach the point anterior reference point, like the infraorbital notch. And as soon as the orbital touches that point, then we will lock the number 1 screw. We'll tighten the number 1 screw. Then we'll move the locking assembly horizontally so that it should coincide. The bite of the stem of the bite fork and whole assembly should coincide with the midline of the face of the patient. Then we will lock the second screw, second screw. And then after that, as soon as all the screws are tight, 1 and 2 are tightened, we will check for the other position, and then we will tighten. After we will also tap the Facebook device so that all the things are in center, and then we will lock the number 3 screw number 3. See this, you can see this is infraorbital notch in the patients, and the orbital pointer in the facebow. And the orbital pointer is coinciding with the patient's infraorbital notch. And as soon as it is coinciding, we are locking the number one screw. Then we will moving it like in this way horizontally, so that all the this stem and the part, this center part should coincide with the patient's midline. And then we are locking the number two screw, and after that this is a third number screw. We are final is the number three screw. This is the transfer rod, and the horizontal is the transverse rod. Now very gently we'll remove the earpieces. Spring is open, and we'll remove the earpieces, and in the same tightened position we'll remove the facebow assembly from the patient's mouth. And we should check all the screws should be tightened properly. Otherwise, it will affect the record. Like you can see in this, the bite fork is attached to the patient's mouth, and it is, and from the side, if you'll see, it is parallel. Then the U-shaped frame is inserted with the external, with the earpieces inserted into the external acoustic meters, and then this. So after that, we will mount the articulator according to the record obtained with the help of Facebook. What is the record obtained? This, see this. This is the posterior reference point, anterior reference point. This is the plane, and the plane of maxilla is. We oriented the plane of maxilla to this horizontal reference plane, and we recorded this plane, this relationship with the help of Facebook. And then we transferred this relationship of the maxilla to the horizontal reference plane in the articulator. And in the articulator, then we are mounting the cast, maxillary cast in the same relationship. So we are transferring the hinge axis of the patient's mouth to the with this hinge axis in the patient's mouth to the hinge axis, to the opening and closing axis of the articulator. So we are reproducing simulating the same axis, opening and closing axis of the patient's mouth in the articulator, like this. This is the mounted maxillary cast, and then in the centric, after recording the centric records, we will mount the mandibular cast like this. So we are simulating the same movements. We are reproducing the same axis as in the patient's mouth, same is in the articulator. We'll mount the cast in direct and indirect mounting of the type. What are the errors which we can see in Facebook recording? Like we are recording the Facebows where we are using the patient's skin as like in the condylar shafts. We are marking the posterior reference point of the patient's skin. So movement of the skin can interfere with the recording. We are in the patient's edentulous ridges, unstable edentulous ridges, and the unstable bases can interfere with the recording. And angle of opening is very small, so it can also interfere. Inter-observer errors also can come. So what are the types of facebows? We have discussed we have discussed about facebows, orientation jaw relation, and the facebows helps us to record the orientation jaw relation. So what are the types of facebows? Facebows are of arbitrary and kinematic type. Kinematic type are the types which records a true hinge axis, and arbitrary type which records the arbitrarily hinge axis arbitrarily. So arbitrary types are the fascia and the earpiece type. In this kinematic facebows, they are we are recording the hinge axis properly. This allows for the precise determination of patient hinge axis, like the graphic representation can you see. And in this, we will as soon as we will record the pure rotation movement of the TMJ with the help of this graph, and thus we'll record the true hinge axis with the help of kinematic facebows. And also the assembly is attached to the mandible in this, unlike the arbitrary ones in which the assembly is attached to the maxilla. And arbitrary facebows use arbitrary or anatomic approximate points on the face as the posterior points, and condylar rods are positioned on these points. They are in the range of 5 mm movements, and also in many studies it is found that this range of movements is sufficient for the proper fabrication of processes, it will not interfere in the function of the processes. So it is wise to use, it is okay to use arbitrary facebows for recording the hinge axis. They are the widely used type of facebows and sufficient for fabrication of most complete fixed partial removable partial dentures. But for full mouth rehabilitation procedures, kinematic facebows are recommended because they record the true hinge axis, and also they need fully adjustable articulators for that purpose. In the arbitrary phase boards, like we have discussed arbitrary phase boards where they are used, and they is like have the two types, fascia type and the earpiece type. Fascia type name is derived from the fact that it has the rest condylar shafts, they rest upon the face. And also in the kinematic phase bow, it is same, the shafts rest upon the face, but fascia type is a arbitrary type. Earpiece type is also an arbitrary type of phasebow, and in this type of phasebow use external auditory meters as an arbitrary reference point, which is aligned with the earpieces. These are the earpieces, and most of the phasebows uses these earpieces as the posterior reference points, and they insert into external auditory meters. Also, it is an easy procedure to do. And also one thing we should keep in mind that there is a compensation given in the articulators which are using the earpiece type of phase bows, because that is not the exact position, that's not the exact position for the posterior reference point. So the articulators, they have that compensation, so that of the which makes use of the arbitrary phase bows. They feature an artificial correction wherever the position of the bow, which should be placed behind the actual hinge axis, is moved forward by about 11 to 13 mm, or rather by the average distance between the acoustic meters and the terminal hinge axis. So they have compensated for this 11 to 13 mm distance between the acoustic meters and terminal hinge axis in the articulators. But these earpieces, they are actually helping us in recording helping us in the phase bow record, because it is an easy landmark to place in. The most commonly used phase bows which we usually use in complete denture fabrication is the Hanaus phase bow spring bow. It is an earpiece phase bow made of spring steel and simple springs open and close to various head widths. This is spring steel. It's the most commonly used. It is very easy and efficient to use, where the parts can be sterilized and mounting can also be direct and indirect, but intercondylar distance cannot be measured with it. Another type of phase bow is a twirl bow. It is an earpiece type of phase bow. It allows the maxillary arch to be transferred to the articulator without physically attaching the phase bow to the articulator. And twirl bow relates the maxillary arch to the Frankfurt's horizontal plane. Then another type of arbitrary phase bows is slidomatic phase bows. They are a type of earpiece, and they use with the Dinar articulators. It is an electronic device that gives reading denoting one half of the intercondylar distance. Whip mix phase bow is also another type of arbitrary earpiece type. It has a built-in hinge axis locator, automatically locates the hinge axis when the earpieces are placed in the external auditory meters. It has an ASION relator assembly with a plastic nose piece. They use an ASION as the anterior reference point. Newer advancements, like there are more advanced techniques which make use of ultrasonic arcs connected to the computers with graphical representations and parameter calculations for programming the articulator. So what are the indications for the use of Facebook? Like we can get a definite cusp to fossa or cusp tip to tip inclined relationship is desired, then we use the Facebook. Like if we are not recording using the Facebook for recording the orientation jaw relation, then what issues can occur? Like there will be deflective occlusal contacts which can interfere with the function of the functioning, which can interfere with the functioning, and these reflective contacts can also produce pain in the temporomandibular joint. Then there's a chain of problems will occur. So for Facebook, where it's required when we need a definite cusp fossa or cusp tip to tip inclined relationship, then we need the Facebook to record the orientation jaw relation. When interocclusal check records are used for verification of jaw positions, like when occlusal vertical dimension is subjected to change, like in full mouth rehabilitation cases, we need to change the occlusal vertical dimension. Alteration of tooth occlusal surfaces are necessary to accommodate the change. So to diagnose existing occlusion in patient's mouth. So we need the facebow when we need the exact position of the occlusion, we need to exactly stimulate the same position of in the patient mouth as in the articulator. What are the advantages? It aids in securing the anterior posterior cast position with relationship to the condyles of the mandible. It acts as an aid in vertical positioning of the cast in the articulator. It assist in correctly transferring the inclination of occlusal plane to the articulator. So that is the case, like the and relationship of the maxilla or the mandible to the condyle to the TMJ in anterior posterior vertical and lateral plane is correctly measured with the help of is correctly positioned with the help of Facebook. And when we not require facebows, like in the when severely resolved ridges, like when we are using monoplane teeth, and in those the monoplane teeth are arranged in balance occlusion, and we do not need the proper cusp to fossa or inclined relationship, then it is not necessary to use a facebow. And also when there is no intended change in the vertical dimension of occlusion, like in the fixed prosthesis, only single tooth are need to be replaced, then there's no need to take the phasebow transfer. And when we do not have the articulators which can accept the transfer like phasebow, when we are recording the phasebow, making the records with the help of phasebow, and we need to transfer those records in the articulator which are of the same brand, like Hanau phasebows have the Hanau articulators, so that the record is transferred to the articulator in the same position, in the same anatomical landmarks, reference points used. What are the need? What is the need for the orientation jaw relation? We need the orientation jaw relation to record the hinge axis, to record the hinge axis, and um, record, to articulate the cast, to make the cast in the to articulate the cast in the articulator in relation to the same axis. It records the relationship of the jaws to the opening and closing axis and transfer it to the articulator. So how will we recording the transverse hinge axis? Why are we recording the transverse hinge axis? This hinge axis is very important because it is a position of point of all the lateral movements, and all the opening and closing movements are which are happening around this axis. Then they are reproduced in the articulator, and also is a repeatable recordable position, so that's why we can record it, and we can this hinge axis position can help us in getting the same position of the in getting the same condition as in the patient's mouth as in the artificial prosthesis. So this was all now this is all regarding the hinge axis. So we this was all regarding the orientation correlation. So we recorded the orientation jaw relation with the help of phase bows, and phase bows are two types, arbitrary and kinematic phase bows. So for the complete dentures, we usually use the arbitrary phase bows, not the kinematic ones, because they are very complex in using. They require, they are very time consuming, and also they are very expensive. So that is not much the requirement of the complete dentures fabrications. And so we can easily use the arbitrary phase bows and get the records as in the and the kinematic phase bow is not necessary for the complete dentures that we can use in the full mouth rehabilitation procedures. And also if we are using arbitrary, so we are that means you can say like we are recording the hinge axis arbitrarily, so that can also produce some discrepancies. So those discrepancies which are produced, if are produced, then we can correct those with the help of selective grinding, because the artificial teeth we are using, we can selectively grind them, and in the articulator. So there's no need of using the technique sensitive procedures. We can easily use the arbitrary phase bows. So this was regarding the orientation jaw relation. Thank you.